Hi, good evening, everyone. So, welcome to this radiology revision for FMG screening June 2026 exam. And in this, we will try to revise all the high yielding topic and the previous year topic. Uh, as we know that the exam is few weeks away, and in this, the major focus should be that what are the areas which are not to be skipped. It is to be noted that out of 300, in order to pass the exam, we need 150. So that means even if my accuracy is just more than 50%, I'm sorted. So I'm very confident in the next 1.5 hour. I'm gonna try to summarize the radiology in a way that out of 12 to 15 questions, you will be able to solve, if not all, then at least 8 to 10, right? So let us try that to utilize this 1.5 hour in the best possible way, right? Okay, so I have summarized it that this is the broad crux that what is being asked in the FMG screening exam as far as radiology is concerned. 1 to 2 questions will be on identify the name of the investigation. 2 to 4 questions on diagnosis based on a particular image. 1 question will be from nuclear scan. 1 to 2 questions will be from radiotherapy. 2 questions on a preferred radiological investigation, and 3 to 5 questions are usually integrated when a radiological image is given and the question is based on management of the patient, right? So what are the topics? I have done a slight change in the overall presentation. Now I will be dividing them into 6 modules. The first module is based on X-rays. The second module will be based on CT scan essentials. The third module is a non-ionizing investigation, which is ultrasound and MRI. Fourth will be nuclear medicine and radiotherapy. Fifth, an important topic of systemic radiology. And the sixth is about the future of radiology. In these 6 modules, I have divided, right? So let us see. So just a brief about the imaging modalities. So X-ray, CT, ultrasound, MRI, PET, and angiography, these are the one. And I hope you understand that X-ray is based on the differential absorption of X-ray by the tissue. And what is the terminology that we use? If a lesion appear whiter, we call it as opaque. If the lesion appear blacker, we call it as lucid. CT also works on the principle of X-ray, but what is an important term that we use in the CT? Hounsfield unit or HU, right? Hounsfield unit or HU. It is to be noted that the bone has got an HLU which is very high, 400 to 1000, and air minus 1000. Now don't forget, water has got an HU value of 0. Now what is the principle of ultrasound? Piezoelectric effect. Piezoelectric effect. What is the principle of MRI? Magnetic field. Magnetic field is the principle of MR. In PET, what is the most important area that we need to remember? 18 FDG, right? 18 fluorodeoxyglucose, right? Now let us look at the first module, which is X-ray fundamentals. And in the X-ray fundamental, this is the first image that I want you to remember, which is a diagram of an X-ray tube. Now it is to be noted that the cathode has a very important part, which is filament. Now filament is made up of tungsten. And what is the purpose of filament? It's a quick revision. I want all of you to write down in the comment whatever answers that you know. Whatever answer that you do not know, highlight them and make sure that you revise it, right? What is the purpose? The purpose is generate electron. Generate electron. Now this electron comes from cathode to anode. Now what is the most important part of the anode? Target. Target is also made up of tungsten. And it generate what? It generate X-rays. It generate X-rays. Now electron is produced due to thermo-ionic emission. Thermo means heat, ion means electron. Thermo-ionic emission. Whereas X-rays are produced due to two reactions. What is the first reaction? Brem-Strong reaction. Don't forget, this was the last FMG screening exam question. Brem-Strong reaction. And what is the second reaction? Characteristic radiation, right? Characteristic radiation. So Brem-Strong reaction is most important in all X-ray tubes. Most important in all X-ray tubes, right? Now what are the important topics of the chest that I want you to remember? Chest X-ray is the most frequently asked. So the first, you should know a normal chest x-ray, right? Now this is a summary. For every topic I have summarized it. You should know a normal chest x-ray, the border of the heart, you should know chamber enlargement, and you should know prosthetic valve. Then you should know pleural effusion, pneumothorax, hydropneumothorax, how to differentiate them. Then you should know pulmonary edema and sarcoidosis, how will you differentiate them. Then you should know miliary TB. You should know congenital diaphragmatic hernia. You should know pneumoperitoneum, and you should know shape of heart. These are the important chest x-rays that you have to know. Now let us see all of them one by one. So this is a normal chest x-ray. What are the important part of this chest x-ray that you need to know? You should know the right heart border formed by the superior vena cava, right atrium, and inferior vena cava. Now you should know the left heart border formed by aortic knuckle, pulmonary trunk, left atrial appendage, and left ventricle. Right? Now what is a key point here? A very important key point here is, remember, this is a trachea which bifurcates into right and left mainstem bronchus at what is that called as? This is called as carinal angle, right? Carinal angle. Now who will tell me which part of the heart lies here? Which part of the heart just lies at the carina? Now this is left atrium, right? Left atrium, and that is why left atrial enlargement. Whenever there is a left atrial enlargement, what happens? There is a carinal widening. Carinal widening is a sign of which chamber enlargement? Left atrial enlargement, right? So aortic knuckle, pulmonary trunk, don't forget they are above the left bronchus, whereas left atrial appendage and left ventricle, they are below the bronchus, right? They are below the bronchus. Now these are the easy areas. This is right lateral costophrenic angle, and this is the left lateral costophrenic angle. Important point is, this is the apex of the heart, which is formed by LV, left ventricle. But don't forget, in tetralogy of a fellow, it is formed by the right ventricle. Tetralogy of the fellow, it is formed by the right ventricle. The next point is, don't forget this. Now a lot of people say that this is the base of the heart. No, this is not the base of the heart. This is the inferior border of the heart, right? Sometimes people do not remember it correctly. Now base has to be opposite to the apex. So the one that is just next to the apex is the inferior border of the heart, which is formed by the right ventricle plus left ventricle, right? Right ventricle plus left ventricle. Now what are the important areas that I want you to remember in this chest x-ray? Now the first thing that you need to remember is the position of the prosthetic valve. Now this is a potential question in the upcoming exam that we are getting. So please remember this. Now please remember, all of them are prediction. I do not know the paper. I am very categorically telling you all these are just prediction on the basis of understanding that these could be the possible question. Now what is happening? Now why I am specifying this? Because lot of noise is now there, ki paper leak and all. So these are just the prediction that you have to be prepared with these kind of questions. So now I can see the two prosthetic valves. Now how to know that which prosthetic valve is what? So it is to be noted that in the exam, usually aortic or mitral can be asked. So if somebody asks you, this is very easy. What you have to do, this is the right cardiophrenic angle. So what you have to do is try to draw an imaginary line from the right cardiophrenic angle towards the left atrium. Now if you ever have any confusion in identifying the left atrium, locate the left mainstem bronchus. Locate the left mainstem bronchus, and wherever it is reaching to the heart border, just try to draw it there, right? And the rule is very simple. Write A for above, A for aortic. A for above, A for aortic. If it is above the line, it is aortic. If it is below the line, then it is mitral. If it is above the line, then it is aortic. If it is below the line, then it is mitral, right? Number one. Number two, you should also know the position of the lines and tubes on the chest x-ray. That is also a potential area that you may get in the exam, right? Now, what are the areas that I want you to be aware about in this? Now, this is cardiac pacemaker. it is to be noted that the cardiac pacemaker can easily be seen. You don't need an imaging for that. But the integrity of the wire of the pacemaker is best assessed on a chest X-ray. Remember this, integrity of the wire of the pacemaker is best assessed on a chest X-ray. Is best assessed on a chest X-ray, right? Now you can see these wires. Normally a pacemaker has got two leads. Okay, two leads. One should be in the right atrium, another should be in the right ventricle. One should be in the right atrium, another should be in the right ventricle. Okay, now you may get a lead here. If you see a lead here, please remember this will be CVC, central venous catheter, and it is to be noted that its tip should be in distal SVC. It should not be in the right atrium, because if it is present in the right atrium, it may precipitate arrhythmia. Right? Now, the last that is expected from you is if you see two white line here. If you're gonna see two white line here, this will be ET tube, endotracheal tube. Right? Endotracheal tube should be 2 inch above carina. Right? It should be 2 inch above carina, because if it is less than that, it will go into one bronchus and it will lead to inflation of a single bronchus and a collapse on the other side, right? Okay. Now let us see some very common X-rays you cannot afford not to know. Now let's quickly see them. If you see the blunting of the CP angle, this will be pleural effusion, right? Very easy X-ray, a pleural effusion. Another case of pleural effusion, but this time you see it on the left side, correct? Another case of pleural effusion, as you are seeing the blunting of the CP angle. It is to be noted that you can see the differential blunting of the CP angle. The minimum amount of fluid that has to be there has to be 150 ml. At least 150 ml of the fluid is required to cause blunting of CP angle on a chest X-ray, right? Now fluid should always go with the gravity, but when you look at the last image, what do you see? You can see fluid is going up like this. Now fluid has no business to go up like this. If the fluid is going up like this, that means the X-ray is not done like this. X-ray is done in this position, and that is why this is a lateral decubitus position. Don't forget this. It's a lateral decubitus position showing left-sided pleural effusion. As little as 10 to 15 ml of the fluid can be seen on this. As little as 10 to 15 ml of the fluid can be seen on a lateral decubitus X-ray. Now examiner is very fond of giving you the X-ray of pleural effusion, pneumothorax, hydropneumothorax. Now let us see them. Now see these X-rays. Now what do we see here? Now I can see air here, sir, but how do I know that this air is not in the lung but in the pleura? So rule is very simple. If air is in the lung, it will be traversed by vascular marking, and vascular marking are seen as thin grayish whitish line. If it is not traversed by the vascular marking, that means air is present in the pleura, right? Now if the air is present in the pleura and you see a straight line, the rule is there are no straight line on the imaging. If you see a straight line on a chest X-ray, it represents a fluid level. It represents a fluid level. So this is a hydropneumothorax. Hydropneumothorax. Whereas this air is going right up to the CP angle, but it is deviating the trachea towards the other side. It is pushing the diaphragm below. Trachea is shifted towards the other side, diaphragm is shifted down. That means air is under pressure. And if air is under pressure, what is this called as? This is called as tension pneumothorax. This is called as tension pneumothorax. So hydropneumothorax, tension pneumothorax, right? Now what do we see here? Air is here, air is here. One does not have a vascular marking. There is no tracheal shift. So this is simple pneumothorax, right? Now, in order to differentiate pneumothorax from tension pneumothorax, don't forget a clinical history will always be given, right? Now, if not given, then mark it as a pneumothorax, right? Can we see this? Another area of air devoid of vascular marking. So another case of pneumothorax. So you have to do a promise to me. Do that promise that pneumothorax, hydropneumothorax, tension pneumothorax, pleural effusion, any device, any lead, if it is there, you are able to answer it on a chest x-ray. This is a free mark, please capture it. Now let us look at some of the diseases on the chest x-ray. So now what I'm going to do is I'm going to show you two images, and I'm going to try to tell you that what are the areas where we go wrong. Every time whenever you see an image, the rule is first you have to think, is it normal or abnormal, and then if it is abnormal, what is the abnormality. So I've got two images in front of you. Every time I'm going to mark 1, 2, tell me what do you see. Do you think that two are normal or abnormal? No sir, both are looking abnormal to me. And when I ask them, you say sir, these are the areas of abnormality, right? Now most of these x-rays will be associated with an accompanying history that will also help you, right? But now if I show you just an x-ray, you say sir, some white areas are seen here, some white area is seen here. So if it is white, I would like to call it as an radio density or an opacity. But can I say this opacity is well defined, and can I say these opacities are ill-defined? I hope all of you will agree with me. And if I ask you, are these central or peripheral? Can I say, you will say that these are central opacities. So can I say these are lobulated, well-defined central opacities? And can I say this is ill-defined central opacity? And this is bilateral hilar lymphadenopathy. Bilateral hilar lymphadenopathy. Now what is this? And this is a classical what is called as bat wing appearance. Bilateral hilar lymphadenopathy in exam in most of the time will be a feature of sarcoidosis, and bat wing appearance will be a feature of pulmonary edema. Will be a feature of pulmonary edema, right? Okay. Now, in comparison, what are we seeing in this image? Now, ignore these two images. Now, I am seeing that there is an X-ray which has got generalized some small doubtful white dots. Some of us are even not able to realize whether there is a dot or not. Now, but it looks like the X-ray is not normal. And when you look at the history, patient has fever, weight loss. So these small nodules scattered in the lung, which are typically diffuse, which are typically bilateral, which are typically less than 5 mm in size. What is my answer? My answer is miliary nodules. My answer will be a miliary nodule, right? Okay. Now, on the other hand, what do you see in these two chest x-rays? Now, these two are actually chest x-ray, but they do not have a problem of the chest. They have a problem of actually abdomen. Now, what do we see? Now, I can see the chest, but I can see air below the left hemidiaphragm. And what I can think of, air below the left hemidiaphragm could be because of air in the stomach. But I can also see air below the right hemidiaphragm. Air below the left hemidiaphragm can be normal, but air below the right hemidiaphragm raises a suspicion. And this is an image of pneumoperitoneum. Right? This is an image of pneumoperitoneum. And what is the most common cause of a pneumoperitoneum? A hollow viscous perforation. A hollow viscous perforation will be the most common cause of a pneumoperitoneum, right? Now, what is this? Now, I can see right hemidiaphragm, but I don't see the left hemidiaphragm, and I can see multiple cystic lucencies over here. Now, if I see this, that's a classical image of CDH. What is CDH? Congenital diaphragmatic hernia. Congenital diaphragmatic hernia. And don't forget this BPL MAR. I have already told you I suffered from it during my exam. I do not want you to suffer. So learn from others' mistake. Bokdalek posterior left. Morgagni anterior right. Bokdalek posterior left. Morgagni anterior right. That means Bokdalek hernia is on the right side. It is posterior and left. Morgagni is on the right side and it is usually anterior. Right? Okay. Now let us see this. So I have a question for you. A 60-year-old woman with 3 days of fever and productive cough. That's a very classical question. Don't blame me if the same is there in the exam. A 60-year-old woman with a 3 days of fever and productive cough, an X-ray is being given. Tell me what is the most likely location of this consolidation. Fever with consolidation is pneumonia, and I can see there is a consolidation in this part of the lung. I can also see the blunting of the CP angle, so there is a pleural effusion. Now you have to tell me in which part of the lung the consolidation belongs to. Yes, what do you think? So in order to do this, let's get a very simple X-ray. Now what are we seeing is that I can see that there is a blunting of the CP angle. I can see there is a consolidation that is obscuring the right heart border. I can see a consolidation that is obscuring the right heart border, and what we know that any consolidation that is obscuring the right heart border lies in right middle lobe. Any consolidation or any pathology that is obscuring the right heart border means lies in right middle lobe. If it is obscuring the left heart border, that means it lies in lingula. So right heart border, right middle lobe, left heart border, lingula. Right? Now who will tell me what is this sign called as? This is called as Silhouette sign. It is called as Silhouette sign. Right? Now what are the other X-rays from the chest that are expected from you in the exam? Are the shape of the heart. Are the very important shape of the heart. So if these shapes are given, it is so easy for you. Now what is this shape called as? Egg on a string appearance. And egg on a string appearance is a feature of transposition of great vessel. And what is this called as? This is called as boot shape heart. And a boot shape heart is a feature of tetralogy of a fellow. But in the real exam, if you ever get confused between them, remember the rule. The rule is that TGV present on first day of life, whereas TOF present on first birthday. What does that mean? That the age of the child will be between 1 to 7 days, and age of the child here will be 5 to 12 months. This is the classical presentation. The second important thing that I want you to remember is that in TGV there is a plethora. There is a pulmonary plethora. That means the pulmonary vascularity will be increased, whereas in TOF there will be oligemia. That means there will be a decrease in the pulmonary vascularity. So if there is a plethora, it is TGV. There is oligemia, then it is TOF. And then this is very easy. I hope everybody can easily appreciate what is this called as. Now this is called as figure of 8 or a snowman shaped heart, which is a feature of supracardiac TAPVC. Supracardiac total anomalous pulmonary venous connection. And what is this called as? This is called as box shaped heart. And a box shaped heart is a feature of Epstein anomaly. Right? It's a feature of Epstein anomaly. So as far as chest is concerned, these are the common chest X-rays that are expected from you in the exam. So make sure that when you are going for the exam, you have done that checkbox that have you revised all of them. Now what are the other X-rays that can be asked in the exam? And these include abdominal X-rays and the special contrast studies. Now in the abdominal X-ray and the special contrast studies, stone on radiograph versus calcification. Number 1, urinary contrast studies, IVP, MCU, RGU, HSG. Barium studies, barium swallow meal, barium meal follow through, barium enema. These should be on your tips. Mark my word, one question is definitely gonna be there in the exam from this. So that means the next 5 minutes is equal to one extra correct question in the paper, right? So now let us see this. So this is the basic concept of the imaging that I want you to remember, and we will quickly revise it. If you see a radiograph, please remember you will see 3 colors. Either it is black, or it is grayish, or it is whitish. If it is black, remember it has to be air. If it is black, it has to be air. There cannot be anything other than air which is black. Now if it is white, and it's a plain X-ray, it's a non-contrast X-ray, it's a simple plain X-ray, it is either bone or stone. If it is black, it has to be air. If it is bone, if it is white, it is either bone or stone. right? Now, if it is stone, it could be either calculus or calcification. If it is in the lumen, then it is calculus. If it is in the tissue, then it is calcification, and that can be easily identified by seeing its shape. However, if it's a contrast study and it is white, remember it has to be contrast. And whether it's a plain study or a contrast study, you need not to bother. It will always be written in the question. And that is why the rule of thumb is always read the question before marking it in the exam. Now let us see this. Now the question says, what is the diagnosis of these plain X-rays? And the moment somebody tells me these are the plain X-rays, automatically this much white will become what? Either bone or stone. Now this is not a bone, then it has to be stone. If it is stone, it is either calculus or calcification, right? Now it is taking the shape of the renal pelvis and calyces, and if it's taking the shape of the renal pelvis and calyces, this will be a staghorn calculus. Staghorn calculus. Whereas this is taking the shape of the kidney. If it is taking the shape of the kidney, this is a calcified kidney. And if it's a calcified kidney, this is a putty kidney. Okay. Now, staghorn calculus are commonly associated with proteus infection. And a putty kidney is commonly associated with renal TB. It is commonly associated with renal TB, right? So don't confuse a staghorn calculus with a calcified kidney. Now see this. Now see this again. Few more plain X-rays. What is the diagnosis of these plain X-rays? Now what do we see in these plain X-rays? Now in this plain X-ray, this is the commonest X-ray that is asked in the exam. One component or one part of the bowel has turned on its own, and it is a markedly dilated bowel, which is called as what? Coffee bean appearance. And if it's a coffee bean appearance, this is a feature of what? This is a feature of sigmoid volvulus. Sigmoid volvulus. On the other hand, what do we see here? What are we seeing? We are seeing multiple air fluid levels. I can see multiple air fluid level. As we can see these multiple air fluid level. Multiple air fluid level. Now it is to be remembered that this is a feature of small bowel obstruction. Multiple air fluid level will be a feature of small bowel obstruction. And what do we see here? The dilated first part of the duodenum and the dilated stomach. What is that called as? This is called as double bubble appearance. A double bubble appearance is a feature of duodenal atresia. It's a feature of duodenal atresia. Double bubble appearance is a feature of duodenal atresia. Are you getting it? Now, see this and tell me what do you think are these images. So your first reply is, I can see a lot of such white thing. Let me go and let's look at the question. And the question says, what is the name of this investigation? And you say, oh, acha, okay, this is a contrast study. This is a contrast study, and don't forget, if it's a contrast study, all that you have to look at is where is the dye. You have to look at where is the dye. If the dye is present in kidney, ureter, bladder, then the name of the investigation is IVP. If the dye is present in bladder and urethra, if it is present in the bladder and urethra, then the name of the investigation is MCU. If it is present in kidney, ureter and bladder, then it is IVP. If it is present in bladder and urethra, then it is MCU. If it is present only in urethra, if it is present only in urethra, then the name of the investigation is RGU. And if it is present in uterus, then it is HSG. Then it is HSG, IVP, MCU, RGU and HSG, right? So what do we see here? I can see kidney, ureter, bladder. So this is IVP, right? But now this question is, what is the diagnosis of this IVP? And the moment I say, oh, why the dye is getting accumulated in the renal pelvis? The dye should have gone into the ureter. It is not able to go here because there is a block here. And if there is a block here, this is a PUJ block or a pelvi-ureteric junction block. That's a pelvi-ureteric junction block. Okay, what is this? What do we see here? Now this is urinary bladder and this is urethra. Right? Urinary bladder and urethra. If the urinary bladder and urethra is opacified with the dye, then the name of the investigation is MCU. If the urinary bladder and urethra are opacified with the dye, then the name of the investigation is MCU. What is MCU? Micturating cystourethropy, also called as voiding cystourethropy. Okay. Voiding cystourethropy, an important MCQ is, it is the investigation of choice for posterior urethral valve or a suspected vesicoureteric reflux. It is the investigation of choice for a posterior urethral valve and a vesicoureteric reflux. Right? Are you getting it? Okay. All right. Now, where do we see the dye here? I can see the dye only in the anterior urethra. And when I am seeing the dye in the anterior urethra, then the name of the investigation is RGU. This is retrograde urethropy. Right? Retrograde urethropy. If the dye is present in uterus and fallopian tubes, if a dye is present in uterus and fallopian tube, then the name of the investigation is HSG. Then it is hysterosalpingography, right? It is to be noted that RGU is done for study of anterior urethra. Right? It is for anterior urethra. Right? Okay. Now let us see some of the diseases on IBP. When the two kidneys appeared to join in the midline, when they are joined in the midline, what is this called as? Horseshoe kidney. It is to be noted that you may get an X-ray of the horseshoe kidney or IVP, or you may get a CT scan of horseshoe kidney in the exam. On the other hand, this is ureter and the terminal end of the ureter appears to be dilated. When the terminal end of the ureter appears to be dilated, this is called as adder head appearance. And adder head appearance is a feature of ureterocele. It's a feature of ureterocele. Whereas if instead of one ureter I see two ureter, and this is what is called as duplicated system. Right? Duplicated system. Right? On the other hand, if the two kidneys appear to be on the same side and I don't see any kidney on the other side, then what is this called as? This is called as crossed ectopic kidney. Right? A crossed ectopic kidney. Right? Now, if you see the anterior urethra and you see the penile urethra and the bulbar urethra, and you see bulbar urethra is narrowed in comparison to the penile urethra, then this qualifies for a urethral stricture. Right? Urethral stricture. Okay. Now, in MCU, you may have different appearances of the MCU. You may have an MCU where the MCU, the bladder appears like a shape of a triangle with multiple diverticulae and a stem below. So if you have this appearance, this is what is called as Christmas tree bladder. This is called as Christmas tree bladder, and a Christmas tree bladder is a feature of neurogenic bladder. A Christmas tree bladder is a feature of neurogenic bladder. On the other hand, if you have a bladder like this and the posterior urethra appears to be dilated like this, this is what is called as keyhole appearance. Keyhole appearance, and a keyhole appearance is a feature of posterior urethral valve. Right. However, if you see that the dye is refluxing into the ureter, if you're seeing the dye is refluxing into the ureter, this is an image of VUR. This is an image of a vesicoureteric reflux. Right? Now, what are the HSG that can be there in your exam? Abnormal HSG is a standard area that they ask. If you have seen them, it will be a cakewalk for you. If you see fallopian tubes are dilated, then this imaging is hydrosalpinx. Okay. If you see only one horn of the uterus, which is typically called as banana shaped uterus, then this is unicornuate uterus. Unicornuate uterus. However, if you see uterus is normal, one fallopian tube is seen and the other fallopian tube is not seen, then this is called as cornual blob, right? Cornual blob. On the other hand, if you see that the two horns are looking like this, but I am not sure whether there is a septa between them or the two horns are separate, then this is either a septate uterus or a bicornuate uterus, any of them. Either a septate uterus or a bicornuate uterus. Now, if the intercornual angle is less than 90 degree, then it is septate. If the intercornual angle is more than 90, then it's a bicornuate uterus. Equivocal image is not gonna be there in your exam, so it will be clear cut. If it is a wide angle, bicornuate, narrowed angle, then it's a septate uterus. Now, GIT contrast studies. If you see the dye in esophagus, then this is barium swallow. This is barium swallow. It is to be noted that you can see neck also in barium swallow as well as esophagus also. It is to be noted that the examiner in the neck may ask you that what is the name of the investigation, or they may ask you these two cup kind structures, right? It is to be noted when they ask you smaller cup, this will be vallicula. If they will ask you larger cup, then this will be piriform sinus, right? Piriform or a piriform sinus. Now, if you see the dye in stomach and duodenum, then this is barium meal. Barium meal. However, if you see the small bowel loop, jejunal loop and ileal loop, then what is this? Then this is barium meal follow through. If you see the jejunal and the ileal loop, then it is barium meal follow through. And if you see large bowel, then this is barium enema. So once again I am repeating: barium swallow, barium meal follow through, and barium enema, right? Now, what are the abnormal images? Now, if you see dilated esophagus with a narrowed distal end of the esophagus, what is this called as? Bird beak appearance. Bird beak appearance is a feature of achalasia. It is to be noted that a lot of students will get confused here. So always there will be a history of dysphagia. And if you ever get confused, is it achalasia or cancer? Look at the pattern of dysphagia. Is it to solid or is it to liquid? If it is more to liquid, it is achalasia. If it is more to solid, then it is cancer, right? So that is what gonna help you in reaching to the correct answer. Okay. Now, though in cancer, this is slightly more longer and more irregular. If it is more longer and more irregular, then we call it as a rat tail appearance, right? But don't forget, the cancer esophagus is not always at the distal end. It could be in the mid part, and when it is in the mid part, what it will happen is it will cause concentric narrowing of the esophagus with proximal shouldering, which is called as apple core appearance. Concentric narrowing with proximal shouldering is apple core, which is cancer esophagus. Okay, what is this? This is called a corkscrew esophagus. Okay, corkscrew esophagus is a feature of diffuse esophageal spasm. And if you see that the stomach has herniated into the thorax with migration of the gastroesophageal junction proximally, then what is this called as? This is called as sliding form of hiatal hernia, right? So 2 weeks before the exam, this is a quickness through which you should be able to answer. Majority of them, these are extremely high yielding topic. Most of them have been asked in the previous exam. There is a very high possibility a lot of them will be repeated in your exam, and you should save your time from these particular questions, which can be utilized in some difficult questions that you're going to come across. Now, what do we see here? I can see the rectum and the sigmoid colon, and I can see multiple contrast filled out pouching. What are these called as? These are called as sawtooth appearance of diverticulosis. Sawtooth appearance of a diverticulosis. However, if you see a protrusion or a contrast filled out pouching in the neck region, then this is a pharyngeal pouch. pharyngeal pouch or a Zenker's diverticulum. Question for you, which was asked in the previous FMG, is between which two muscles Zenker's diverticulum is present. Write down in the comment that in which two muscles the Zenker's diverticulum is present, right? And we will answer it in some time. All right. Now what do we see here? I can see some more barium images where I can see this sign is called as coiled spring appearance, right? This is called as coiled spring appearance. And what is the other one? What is the other one? This is a claw sign. A coiled spring appearance or a claw sign, they are seen in which condition? They are seen in intussusception. Intussusception, right? So this is not a CT time, but a CT also you can see this as a bowel within a bowel appearance. Bowel within a bowel appearance, also called as donut appearance. Bowel within a bowel appearance, also called as donut appearance. Nothing new. Very good, bache. Cricopharyngeus. And what is the second one? You have to tell me which is the second one. Okay. Now what do we see here? Now I can see the large bowel, but I don't see any septae in the large bowel. So I would like to call it as loss of ostration. And a loss of ostration is called as lead pipe appearance. Loss of ostration is called as lead pipe appearance, which is a feature of ulcerative colitis. A loss of ostration or a lead pipe appearance is a feature of ulcerative colitis. Okay. Now, other X-rays that can be there in the exam could be orthopedic X-rays and some X-rays like a skull X-ray, vertebral X-ray, and don't forget coin versus button battery. These are extremely high yielding. You have to know them. So let us quickly see them. So what is this called? So without going into depth, we'll just quickly revise them. What do we see? This is called as punched out lytic lesion, also called as raindrop appearance of multiple myeloma. Now this is called as geographic lytic lesion. Yes, I'll share the PDF. Geographic lytic lesion with beveled edges. This is seen in eosinophilic granuloma. Right. Geographic lytic lesion with beveled edges are seen in eosinophilic granuloma. Now I will share this PDF with you. Then this is called as silver beaten appearance. Silver beaten appearance is seen in raised intracranial tension. Right. Now this slides, this PPT that I have created is a pure gold. And I am telling you, it will not take more than 40 minutes for you to revise it. And I can bet on this that this is sufficient to get at least 50 to 60% question of the radiology correct in your paper. Okay. And what is this? Now this is called a hair on end appearance. But you have to promise me that you are not doing any of them wrong in the paper. Right? Thalassemia. Hair on end appearance is seen in thalassemia. And this is salt and pepper appearance of hyperparathyroidism, and this is called as cotton wool skull. Cotton wool skull of Paget's disease. Cotton wool skull of Paget's disease, right? Similarly, shape of vertebrae are also something that should be on your tips once you're gonna go for the exam. So what is this? This is called as bullet shaped vertebrae, and a bullet shaped vertebrae is seen in achondroplasia. Okay, what is this called as? This is called as what? This is called as fish mouth appearance. Fish mouth appearance is seen in osteoporosis. What is this called as? They called it H-shaped vertebra. H-shaped vertebra is seen in sickle cell anemia. It is seen in sickle cell anemia. What is this called as? It's called a picture frame vertebra. Picture frame is seen in Paget's. Right. Now what is this called as? This is called a rugger jersey spine. Rugged jersey spine is seen in ROD, renal osteodystrophy. This is called a ivory vertebra. Ivory is seen in Paget's disease. And this is when one vertebra is collapsed. This is called a vertebra plana. Vertebra plana is seen in eosinophil granuloma. And the last one, I believe everybody already know, bamboo spine is a feature of ankylosing spondylitis. Bamboo spine will be seen in ankylosing spondylitis. And not to forget, coin versus button battery. If you see a homogeneous appearance, then it will be a coin. However, if you see one circle and then you see another circle within this circle, which is called as a double ring sign, then this is button battery. And it is to be noted that a button battery becomes a surgical emergency, right? Obviously, you know how to differentiate whether it is in the esophagus or in trachea by looking at the shape. If it is like a slit on a frontal x-ray, then it is in the trachea. If it is flat, then it is in the esophagus, right? Okay. Now, those are the x-rays. Now, let's talk about what are the CT essentials that you have to know. So, one is anatomy on a radiological section, which is an important area that I want everybody to be aware of. So, the first is normal CT of the head. Then you should know about various type of hemorrhages. You should know about infarct, and you should know about the ring enhancing lesion. So now let us try to talk about them. So what is this? This is a very commonly asked section in the exam. Now what do we see? These black areas that you could see are what? These are the frontal horn of lateral ventricle. These are the frontal horn of lateral ventricle. Now along with them, this oval shape area that you could see is caudate nucleus, or to be more precise, head of the caudate nucleus. And this triangular shape area that you could see, which is marked as 21, is called as lentiform nucleus, right? Now this is called a lentiform nucleus. That is to be noted that the lentiform nucleus has got a medial part and has got a lateral part. It is very easy to remember, and this way is P for peripheral, P for putamen, P for peripheral, P for putamen. And then here you have another oval shaped structure, and this oval shaped structure has been called as thalamus. Okay, in between them we have this bow shaped structure, which is not a gray matter but a white matter, and this is called as internal capsule, right? That is to be noted that the internal to the lentiform nucleus has to be internal capsule. External to the lentiform nucleus will be what? External to the lentiform nucleus will be external capsule. Both are white matter. And then what do we have here is another gray matter, and this gray matter has been termed as insula. So this is a very commonly asked section in the exam. Where is caudate nucleus? Where is thalamus? Where is lentiform nucleus? Where is globus pallidus? Where is putamen? That these are the ones that you should be able to answer. Now the hemorrhage is a 100% question in the exam. If you see a biconvex hematoma, remember a biconvex hematoma, what is this? This is idly shape hemorrhage, and if it is idly shape, it is EDH. Id for EDH, correct? However, if you see a crescent shape hemorrhage, which is commonly called as banana shape hemorrhage, then it is SDH. Then it is subdural hemorrhage, right? Now, if you see that the blood is going into the sulcal spaces, if the blood is going into the sulcal spaces in the cisterns, then it is SH. Then it is subarachnoid hemorrhage. And if you see blood within the brain parenchyma, then obviously this will be intraparenchymal hemorrhage. In intraparenchymal hemorrhage, so EDH, SDH, SAH and intraparenchymal hemorrhage. And then you have one more disease, which is DAI, diffuse axonal injury. In a diffuse axonal injury, patient will be unconscious after trauma, but CT will be normal. So if it's an unconscious patient after trauma and CT is normal, then think of diffuse axonal injury. Now, sometime CT may show small hemorrhage. So sometime it may show tiny hemorrhagic foci at gray white matter junction. Tiny hemorrhagic foci at gray white matter junction, then also thinks of diffuse axonal injury, right? So EDH, SDH, SAH, intraparenchymal hemorrhage and diffuse axonal injury are the 5 trauma images that should be on your tips. Now, what about a stroke? Now, it is to be noted that the first investigation to be done in a stroke is NCCT, right? In NCCT, and on NCCT, don't forget, if it is ischemia, in the first 6 hours, it will be normal. As you can see, this area looks normal. However, after 6 hours, what will happen? The involved area will become hypodense. In the first 6 hours, it is normal, and after 6 hours, the involved area will become hypodense. So these are the 2 typical examples of ischemic stroke on a non-contrast CT, right? Okay. Now, the other thing in the CT that the examiner love asking is the calcification pattern. Now, it is to be noted that if a calcification pattern is diffuse nodular, right, large nodular areas of calcification in the brain, then this is toxoplasmosis. This is toxoplasmosis. Whereas if you see calcification in the shape of a bracket, then this is corpus callosal lipoma. This is corpus callosal lipoma. Okay. Now, if you see calcification along the ependymal lining, now calcification along the ependymal lining, now this is called as calcified subependymal nodule. Calcified subependymal nodule, this is called as candle dripping appearance. Now, candle dripping appearance is a classical appearance of tuberous sclerosis. It's a classical appearance of tuberous sclerosis. Whereas when you see small calcification scattered in the brain, this is what is called as starry sky pattern. And a starry sky pattern is a feature of neurocysticercosis. A starry sky pattern will be a feature of neurocysticercosis, right? Now, if you see calcification along the ventricular lining, now this is called as periventricular pattern, right? Periventricular pattern, and periventricular pattern is a feature of CMV, right? So diffuse nodular in toxoplasmosis, periventricular in CMV, right? Now, if you see calcification along the gyri, now this is called as tram track pattern, and a tram track pattern is a feature of Sturge-Weber syndrome. A tram track pattern is a feature of Sturge-Weber syndrome, right? Important, very important calcification pattern that one should remember. Now, as I told you, differences between 2 diseases. Now I have got again 2 CTs for you. Now what do you see? You can see something here, you can see something here. Now both are looking as a white periphery and black center, white periphery and a black center, and we would like to call them as ring enhancing lesion. Examiner love asking ring enhancing lesion. Now, but what is the difference between these two? Sir, this is looking large. Sir, this is looking small. I say, remember, this is the rule. Now, if it is large enough, imagine it in the body, and if it is large enough that you think that it can come into your wrist, it is large. But if you think this ring is small, that it can come only in your finger, then it is small. If it's a large ring enhancing lesion, remember it is either GBM or an abscess. It is either a glioblastoma multiforme or an abscess. Look at the history, and in your exam, if the examiner wants you to mark the answer as abscess, fever will be given. Right? Now, if it's a small, remember it will be either TB or NCC. It will be either TB or NCC. Look at it carefully. If you see a lesion with an eccentric nodule within, this is a scolex, and scolex is a diagnostic feature of NCC. In TB, there will be no scolex, right? So normally in an FMG screening exam, they don't go beyond it. In a PG entrance, they ask it, what will you do now? And then you will do spectroscopy. But I have not seen that spectroscopy being asked in the FMG screening exam as of today. Now, you may also get toxoplasmosis. Now, it is to be noted that the toxoplasmosis could be a congenital infection, which is a torch infection, which is characterized by calcification in brain. Or it could be an infection in immunocompromised patient. It could be an infection in an immunocompromised patient, and then it will present as ring enhancing lesion. So if you see a ring enhancing lesion in an immunocompromised patient, a small ring enhancing lesion in an immunocompromised patient, then you should think about toxoplasmosis, right? Okay. Now if I have to put a bet, I will put a bet on this, that examiner will ask you this in the exam, and that's an anatomy of the chest on the CT, right? Now, if you get an anatomy on the chest on the CT, now just remember that at what level the section has been taken. As I can see this image, I can see this image, I can see this image, or I can see this image. Now, what I want all of you to focus on this yellow line. See at what level this yellow line I can see here, I can see here, I can see here, I can see here. So that means depending on at what level the section has been taken, you're gonna see different structure. But my problem is that in the exam, only this image will be there. So always look at this central black structure. And if this black structure is seen, this is trachea. And don't forget, if the trachea is seen, that means you are above carina. You are not below carina, you are above carina. And this black structure is esophagus, which may have air or may not have air. So if you are above carina, you are reasonably sure that this is how the, let me use a different color, this is how the arch of aorta is. That means these are the branches of the arch, correct? These are the branches of the arch, and that is why this will become right brachiocephalic trunk, this will become left common carotid, and this will become left subclavian artery, and this is likely superior vena cava or maybe right brachiocephalic vein. Are you getting it? Now, if I go down, I can still see trachea, but this will become arch of aorta now, and this will become superior vena cava, correct? Now, if I go further down, now I can see this is right bronchus and this is left bronchus. Right bronchus or left bronchus? Now, point to be noted is what is happening here. This is ascending aorta, this is descending aorta, and what is this? This is esophagus. So ascending aorta, descending aorta, right bronchus, left bronchus, and esophagus. Are you getting it? Now I have gone further down. Now this time what I can see is I can see the heart, and it is very important to understand that since it's a transverse section, don't forget that this side is anterior, this side is posterior, this side is right, and this side is left, right? So now I can see these are the four chambers of the heart. Okay, and now immediately I will think about this is the posteriormost chamber of the heart, and that is why it will be left atrium. Now if this is left atrium, the rest is easy. This will be left ventricle, this will be right ventricle, and this will be right atrium. So right atrium, right ventricle, left atrium, and left ventricle, these are the four chambers of the heart. Is it okay? Are you getting it? Now what do we see here? Now, once you know normal, it is very, very easy to identify the abnormality. What I can see this is ascending aorta, which looks normal to me. This is descending aorta. I can see a flap within the descending aorta. So this will become aortic dissection. Now you have to write down in the comment section that according to Stanford classification, this aortic dissection belongs to which category, right? Another case, and this time the dissection is not involving descending aorta, but it is involving the ascending aorta, right? In this case, I can see that the dissection is involving both ascending and descending aorta, right? So as per Stanford classification, this is something that I want you to remember for sure. As per the Stanford classification, we have got type A and type B. Type A and type B. Now what is type A? Type A is if the ascending aorta is involved. What is type B? If the ascending aorta is not involved. If the ascending aorta is involved, then it is type A. If the ascending aorta is not involved, then it is type B. Involvement of ascending aorta is a surgical emergency. It's a surgical emergency. If it is not involved, then the treatment is medical management. If it is not involved, then the treatment is medical management, right? Now what do we see here? Ascending aorta is here, looks normal. Descending aorta is here, looks normal. And now I can see the pulmonary trunk. And I can see a filling defect within the pulmonary artery. A filling defect within the pulmonary artery is a classical appearance of pulmonary embolism. Pulmonary embolism. And the investigation of choice to diagnose pulmonary embolism is CT pulmonary angiography, and screening test is assessment of D-dimer. Right? Okay. Now, CT of the abdomen is also something that can be there in the exam. Now, see at what level the section has been taken. So, automatically, this structure will become liver. This structure will become spleen. And this black structure means an air containing structure is stomach. Now, this rounded structure, which is contrast filled, is ascending aorta. Is abdominal. A is fine, not ascending aorta. Abdominal aorta, right? My fault. Abdominal aorta. Whereas this another vessel just to the right of the abdominal aorta is inferior vena cava. Right? This is inferior vena cava. Right? Now this is at this level. If I gone further down, see at what level I have come. So now I can see right kidney and left kidney. Spleen will continue to be seen here. This will be liver, but now I can see this horizontal vessel. A large horizontal vessel in the liver should represent portal vein. This should represent portal vein. Now, if I go further down, now what I see is liver. What I see is spleen, and now I can see another gland in the center, which is pancreas. And now I can also see this fluid filled structure, and this fluid filled structure should be gallbladder, right? Aorta and IVC continues to be seen similarly, right? On a coronal section, it is easy to identify liver, it is easy to identify spleen as well as kidney, but don't forget, I can also see the muscles, and these are psoas muscle. I don't know why, but it's a favorite muscle that the examiner asks on CT imaging, psoas muscle, and you should be able to answer it. Okay. So those are the very, very standard images of the CT that are expected from you, frequently asked topic, high yield topic, and also previous year topic. Now let us look at the module 3, ultrasound and MRI basics. So two important signs of the ultrasound that I want you to remember is acoustic enhancement. When you see more brightness behind a fluid containing structure, and it is to be noted that the acoustic enhancement is the marker for Acoustic enhancement is the marker for fluid. And if you see this area and then you see a black area behind, then that is shadowing, which is a marker of calculus. Acoustic enhancement is the marker for fluid and acoustic shadowing is the marker for calculus. Now, in terms of ultrasound, gallbladder calculus is something that I want you to be aware of, and then you should be aware about some of the gynae images. That is to be noted that this is how the normal ultrasound look like, and this is how a twin pregnancy look like. Yeah, twin pregnancy look like, and when you see a thin membrane between them, then that will be called as T sign. And when you see a thick tissue between them, that will be called a lambda sign. If it's a T sign, this is a sign of monochorionic diamniotic pregnancy. If it's a lambda sign, then it is dichorionic diamniotic pregnancy. Dichorionic diamniotic pregnancy, and that's a normal pregnancy with an embryo with a yolk sac, right? Okay, now this is how a mid-size pregnancy look like at around 12 week, 13-14 week, when you can see leg, abdomen, chest, skull, face and the vertebral column. And when the skull is unable to develop, what is this called as? This is called as anencephaly, right? Anencephaly. Other ultrasound images that are frequently asked in the exam are these images, and these are called as Doppler images, right? Now, depending on which vessel has been shown to you in fetal growth restriction, what are the three major vessels that we check? We check umbilical artery, remember, we check uterine artery, and we check MCA, middle cerebral artery, right? We check middle cerebral artery. Now, if you see an early diastolic notch in a uterine artery, it's a sign of PIH. Early diastolic notch in a late pregnancy is a sign of PIH. PIH, right? Are you getting it? Okay. Now, these are the Dopplers of the umbilical artery. Now, this is a normal Doppler. This is decrease in diastolic flow. There's a decrease in the diastolic flow, which is the earliest sign of uteroplacental insufficiency. It is to be noted that the decrease in the diastolic flow is the earliest sign of uteroplacental insufficiency. Then this is absent diastolic flow, and this is reversal of diastolic flow, and this is reversal of diastolic flow, which is a sign of severe IUGR. It's a severe FGR, right? Okay. Now, in MR, what are the important clinical applications? Please remember, tumor, soft tissue lesions are very well seen. Spinal cord, don't forget, if there is any disease that is involving spinal cord, MRI will be the preferred investigation. If you want to localize a brain tumor, MRI is a preferred investigation. And don't forget, meningioma shows dural tail sign, acoustic neuroma shows ice cream cone appearance. These are some very, very standard areas, right? Knee joint, please remember, meniscal tear, ACL rupture, MRI is a standard non-invasive gold standard. MRI is nowadays standard non-invasive gold standard that is to be done. Early osteomyelitis. Early osteomyelitis, MRI is a preferred investigation. Intraosseous extent of a bone tumor, MRI is a preferred investigation, right? These are some of the important clinical pearls that you need to be aware of. MRI contraindication, free lying ferromagnetic foreign body inside the body. A free lying ferromagnetic foreign body inside the body is an absolute contraindication, like an iron foreign body inside the eye. An iron foreign body inside the eye. Now, if you see an MRI, don't forget T1 weighted image and T2 weighted image, right? What is the easiest way to remember? World War II. What is World War II? Water is white on T2. Water is white on T2. No structure can be more white than water on a T2 weighted MRI, water is virtually hyper intense to everything on a T2 weighted image, right? Okay. Now, these are some of the tables. You have to be very, very quick. You have to make sure that you remember this, because a lot of time the values are being asked in the exam. So first is the important investigations and the radiation doses in those investigations. For a chest x-ray, it is 0.02 millisievert. It is 0.02 millisievert. For a mammography, it is 0.2 to 0.8 millisievert. For an IVP, it is 2.5 millisievert. For a barium enema, it is 7 millisievert. For a CT chest, 8 millisievert. For a head, 2.3 millisievert. For an abdomen, 10 millisievert. And for a bone scan, 4 millisievert. Very, very important values should be on your tips once you're gonna go for the exam. Now, it is to be noted that a patient should not be given more than 50 millisievert of radiation in an year, whereas an occupational worker should not be given 100 millisievert in 5 years, right? So for a patient, it is yearly. For an occupational worker, the cumulative dose is for 5 years, right? Pregnant patient ideally should not be given any radiation, but if you have to remember a value, it is 5 millisievert per term. Whereas for pregnant occupational worker, it is 2 millisievert for the female, which is equal to 1 millisievert to fetus. 2 millisievert dose to this pregnant female at the surface of her lower abdomen, which is equal to 1 millisievert dose to the fetus. And for general public, it is 1 millisievert per year, right? Okay. Now, what are the other values? It is to be noted that how to measure radiation can be measured by exposure dose, absorbed dose, equivalent dose, and effective dose. Exposure, absorb, equivalent, and effective. Conventional unit and SI unit. So conventional unit, don't forget, all starts with R. R. So Roentgen, rad, and rem. SI unit, exposure dose, coulomb per kg. Absorbed dose, gray. Red and gray, both are color. Color will remain together. Equivalent dose, rem and sievert. Ram and Sita will remain together. Color will remain together. Ram and Sita will remain together. Effective dose does not have a conventional unit. It has only the SI unit, which is sievert, right? So exposure, पहले expose करेंगे, फिर absorb होगा, फिर equalize होगा, and finally it will be effect. So exposure, absorb, equivalent, and effect. Roentgen, coulomb per kg, rad, gray, rem, sievert, and sievert, right? Now radioactivity, sometimes they can also ask, which is Curie as well as Becquerel. Curie is conventional and SI is Becquerel. Now this is a TLD, which is radiation monitoring device. It's a radiation monitoring device used by the radiation worker, and this is the symbol of biohazard or radiation hazard. Wherever there is a radiation hazard, this symbol has to be placed there, right? Okay. Now some small points. It is to be noted that MRI contrast agent that we use is gadolinium, right? Gadolinium. So gadolinium does not cause anaphylaxis. It does not cause anaphylaxis, and hence test dose is not required. Okay, but you have to be careful in CKD patients. Careful in CKD patient. Now, ultrasound contrast agent. Ultrasound contrast agents are Levovist and Sonoview. Right? No allergy, no nephrotoxicity. No allergy, no nephrotoxicity. And then you have got iodine dye. Iodine dye, risk of allergy, risk of nephrotoxicity. Both the things. Risk of allergy, risk of nephrotoxicity. And because there is a risk of allergy, what is required? Test dose is required. Test dose is required. Now, because there is a risk of nephrotoxicity, KFT should be measured. KFT should be measured, right? Okay. Then another important list, radio sensitivity, right? G2M is the most sensitive stage of the cell cycle. S is least. Ovary and testis are most. Vagina, bone and CNS are least. Tissue, bone marrow is most. Nervous tissue is least. Now cell type, if it's an undifferentiated cell, it is more sensitive. If it's a dormant or a quiescent cell, then it is resistant. Okay. Blood cell, lymphocytes are most, platelets are least. Lymphocytes are most, platelets are least. Now, in terms of tumors, Wilms is highly sensitive. But what is the full form of Wilms? Wilms-Ewing's lymphoma, myeloma and seminoma. Wilms-Ewing's lymphoma, myeloma and seminoma are highly sensitive. HOM is hepatoma, osteosarcoma, melanoma and pancreatic carcinoma. These are least sensitive. Highly sensitive Wilms, least sensitive hepatoma, osteosarcoma, melanoma and pancreatic carcinoma. Now, similarly, half-lives. Technetium 6 hours. Iodine 123 13 hours. Iodine 125 60 days. 131 8 days. 132 2.3 hours. Phosphorus 32 14 days. Cobalt 60 5.2 years. And iridium 192 74 days. You can also remember 18 FDG, which is 110 minutes, and a newer compound nowadays which is gallium 68, which has a half-life of 68 minutes. Right, gallium 68, which is 68 minutes. Right, now radiotherapy, the few questions that are expected from you is, first, what is the type of radiotherapy? So nowadays we give radiotherapy in divided doses, and when you give in divided doses, this is called as standard fraction. Now what is the standard fraction? Please remember, 1.8 to 2 gray per day, 5 days in a week. That means you don't give it on Saturday and Sunday, and it is OD. OD means once a day, OD, and 6 to 8 weeks. But I can hyperfractionate it. Now once I am going to hyperfractionate it, remember, instead of OD, I will give BD. Instead of once a day, I will give BD. But what I'm going to do now, I'm going to give 1.1. I'm going to give 1.1 to 1.2 gray per dose. I will give 1.1 to 1.2 gray per dose, right? BD, I'm going to give 5 days in a week, and I will give for 6 to 8 weeks. I'm going to give for 6 to 8 weeks, right? So that is what I have to remember. Okay. Now, hypo is not important. Prophylactic cranial radiations is something that I want you to remember. It is given as a prophylactic radiation to the brain, commonly given for small cell cancer of lung. Small cell cancer of lung. Now, the commonest type of therapy that we are doing is teletherapy. It is to be noted that the most commonly used machine previously used to be cobalt, but nowadays it is linear accelerator, which can give X-rays as well as electron. This was a question last year. Linear accelerator can be used for the production of X-rays as well as electron, and that is what I want you to be aware of. Okay. All right. The last amongst the topic is these investigation. If you see the common bile duct and the pancreatic duct only, then this will be MRCP. However, if you see an endoscope along, then this will be ERCP. So if endoscope is not seen, then it will be MRCP. If the endoscope is seen, then it is ERCP, right? Then it is ERCP. Now, point to be noted is this. Please see this image. What's very, very important area. Now, this is common bile duct. This is pancreatic duct. Now, common bile duct and pancreatic duct, if they are dilated, this is called as double duct sign, right? Double duct sign. And a double duct sign is a feature of periampullary cancer. A double duct sign is a feature of periampullary cancer. Whereas what do we see here? In the intrahepatic biliary radicals see dilatation and constriction, dilatation and constriction. Now this is called as string of bead appearance. A string of bead appearance is a feature of primary sclerosing cholangitis. A string of bead appearance is a feature of primary sclerosing cholangitis. MRCP complication, most common PYQ. No, bache, ERCP complication. MRCP does not have a complication because you are not giving a dye and it's a non-invasive test. The complications are with the ERCP. So ERCP induced pancreatitis is the most common complication of ERCP, followed by perforation. And ERCP induced pancreatitis followed by perforation. Now, what are the future predictions? What is the life or future of radiology? Now, these are the topic in discussion. Examiner can little bit ask you about AI in radiology. They can ask you a special type of CT that has been available nowadays, photon counting CT, which is unlikely to be in an FMG screening exam, but they can definitely ask you about the MRI safety and the contrast, nephrotoxicity, allergic reaction, which I have spoken about it. They can ask you about PET. They can ask you about PET plus CT, which is PET CT. They can ask you about PET MRI, which is PET plus MRI. They can ask you newer compounds of the PET like PSMA PET. Now it is to be noted that PSMA PET is for prostate cancer metastasis. PSMA PET is for prostate cancer metastasis. Now there is a lot of discussion on the dual energy CT nowadays, where instead of one X-ray tube, nowadays we are using two X-ray tube for renal stone characterization, right? For renal stone characterization. Elastography or a fibroscan has come up as a very good investigation for assessment of liver fibrosis. For the assessment of liver fibrosis, it's a non-invasive technique for assessment of liver fibrosis, right? And the newer CCT protocol, these are no longer newer, but a triphasic CT for characterization of liver masses. For characterization of liver masses. But whatever that we have covered, if you know this is a quick revision of the radiology. In 1.5 hours, I have tried to cover the most commonly asked questions, frequently asked questions, which we say is high yielding topics or the previous years. Please make sure that you are very sorted with them, and I'm very certain that at least 6 to 8 you will be able to tick right if you know this much related to that, right? Chalo, that is all from my side, guys. Thank you very much for listening to me, and do let me know that if we can do anything else for you from DBMCI side. I will pray from the Almighty that all of you come out with flying colors in your FMG screening exam, and with a lot of happiness, with a lot of proud. You can write it to us, you can send a message to us, sir, yes, I passed my exam. Just pull up your socks, make sure that whatever has happened in the past, ignore. Please, for the next few days, nothing else is more important for you than your exam. Make sure that you're gonna utilize your time in the best possible way, and I am very certain that together we will be celebrating your success of passing the FMG screening exam.